glaucoma. So I would request the next speaker, Dr. Reena Sharma, until her presentation is set up. We'll just have one or two questions. So the 2 points which I would like to share with everybody, taken from this particular talk itself, is that whenever you are diagnosing a case of advanced disease, never go with the OCT, because of the floor effect, it will not give you a correct outline that where your patient is actually standing. Second is that whenever you're planning to do a surgery, that too with a high pressure in advanced glaucoma, please go with a gradual decompression, but don't be scared of wipeout phenomena. Wipeout phenomena are rare, but yes, they are reversible also. But for that, meticulously closure of the wound, that is a tight sealed wound, is actually required with a gradual decompression. And anything more to add, sir? Vineet, sir?
Fantastic talk, given good points as to how we should handle. How many of these do you treat all your advanced glaucomas with mannitol before you take them up for surgery?
So after I left India, I've never used mannitol in 22 years. It's something which is not, it needs monitoring for elderly patients, so we don't do mannitol at all. Just as somebody said, slow decompression, pre-place releasable sutures, that's usually enough for these patients. Or you can put AC maintainer for high-risk cases. So especially young patients, high myopes, you put AC maintainer to maintain the pressure during the surgery so it doesn't collapse quickly.
So do you give them acetazolamide?
No, not at all.
Nothing. So you just take them up. Do you give them steroids prior to?
Yes, so that definitely we do. So I would, like the last session also said, so certainly if they are on red eye causing drops, we'll stop them, FML for a few weeks and Diamox if required. But for advanced glaucoma, because in the Afro-Caribbeans, I'm doing combined surgery because the traps heal after 6 months or 1 year. So the tube is already there and the tube is closed completely. So you can open up whenever you want by lasering the suture nylon and then taking out the ripcord suture.
Thank you.
Dr. Saurabh?
Nice talk, sir.
I have one question.
Just wanted to ask one question.
Yeah.
Like if the advanced one-eyed glaucoma patient has cataract, so would you prefer to do combined cataract glaucoma treatment together or one by one?
Yeah, so this is a very useful and important question. So it all depends on the pressure. If the pressure is uncontrolled, I would do a drainage surgery first and then them to understand that we will need to take out the cataract afterwards. If the pressure is reasonably well controlled, my approach is to do a phaco ECP first, so that gives us some control along with the ECP, and then do a drainage procedure afterwards. Because once you do trabeculectomy, the cataract will be there, and then you will have the failure of trabeculectomy. So my approach is to take out the lens much earlier on these patients, and then do the drainage procedure if the pressure is controlled.
Does that increases the risk of wipeout because we are subjecting a one-eyed patient with very advanced glaucoma to the two surgeries?
Correct. So that's the thing I was trying to say, that if you control the pressure immediate post-op period very well, so on the same day, so I often do their surgery in the morning, see them again in the afternoon, see them next morning, because these are the pressure fluctuation which causes the wipeout. So if you monitor them well, if you treat them well, then I have only seen one patient in 17 years, which was a patient done by angle closure eye, cataract, and then not seen for 2 weeks in a colleague's farm because they were not glaucoma trained. So, and the patient comes with a counter fingers and a hand movements vision afterwards. So that's very rare. I have not seen in my practice wipeout at all.
And how do you test the IUP? It's by applanation after 6 hours?
Yes, applanation, yeah. Okay. Or eye care, whichever is available.
Thank you very much. With that, we move ahead to Dr. Reena, and I would request all the discussant to please note down your questions so that we can take it at the end of the session. So, Dr. Reena, up to you.
Okay, thank you, ma'am. Good afternoon, everyone. So today I would be speaking on the topic pragmatic approach with the newer drugs in glaucoma. So we all know that as far as anti-glaucoma drugs are concerned, we have come a long way since the first introduction of pilocarpine in the year 1877. Since then, multiple drugs have been introduced, but we are still to get the ideal anti-glaucoma drug that we want. And for last nearly 2 to 2.5 decades, we have been considering prostaglandin analogs to be the first drug of choice. Now, why do we need these new drugs? Is because majority In fact, all of the anti-glaucoma drugs that we are using have multiple systemic as well as local side effects. Plus, we also have some gray areas that we have not worked upon till now. That includes the neuroprotective effect that is needed. We need more drugs to act on the trabecular meshwork that is actually the primary site of problem. We need preservative-free drugs to prevent the ocular surface problems. Patient with difficult conditions like asthma and heart disease and allergy, uveitis, there we do not have many options, so we need newer drugs. Multiple drugs with novel mechanism of action, new formulations, and new drug delivery mechanisms are currently in development, but the newer options that have become available include the rho kinase inhibitors, which have become a widespread usage, include natarcidil and ripacidil, and the promising drugs that are not yet available in India include natarcidil latanoprost combination and latanoprostene bunod. So a little about these. ROCK inhibitors basically act to inhibit the enzyme Rho kinase, which primarily is involved in extracellular matrix reorganization in the trabecular meshwork, and therefore Rho kinase inhibition, they primarily decrease the aqueous humor outflow, but in addition are also proven to provide some neuroprotective effect and also act as anti-scarring, which may be beneficial when we take up the patient for trabeculectomy surgery. Ripacidil was the first anti-ROCK inhibitor that was introduced, and it is used in a percentage of 0.4% in BD dosage. It decreases IOP within 2 hours of installation and has been proven to do consistently over a period of full 1 year. And what is important to know is that it lowers the IOP not only in the higher ranges, that is above 21 mmHg, but also in the lower normal and in the borderline cases. So that is where it may be beneficial in early open angle glaucoma patients and also in glaucoma suspects. In addition to ocular hypertension and open angle glaucoma, the drug has also been found to be very beneficial in patients with normal tension glaucoma, even angle closure glaucoma, and steroid induced glaucoma. So, the side effects, as far as ripacidil is concerned, the majority of the side effects occur locally. The systemic side effects are very rare. Conjunctival hyperemia was found to be the most common side effect, affecting almost 65.3% of the patients, though it was found to be often mild and transient. However, the post-marketing studies that have been done with assessing the side effects of ripacidil, it has been found that the conjunctival hyperemia is found even in a lower percentage of patients, affecting only around 4% of the patients who use the drug. Natarcidil is the next ROCK inhibitor that became available. The advantage with this drug is that apart from being a ROCK inhibitor, it also lowers the episcleral venous pressure and also decreases the aqueous outflow production by causing norepinephrine transporter inhibition in the ciliary body. So, given the multiple mechanisms, the drug may be or is considered to be more efficacious. The active metabolite is netacidil AM, which decreases IOP within 2 hours. A peak is there at 8 hours, and the effect lasts for at least 24 hours after the dosing. So it's used in a percentage of 0.02% as once daily, thereby taking care of the patient's compliance. Phase 3 Rocket 4 studies have found netacidil OD to be non-inferior to timolol BD, and this efficacy has been found to be there consistently over a period of 1 year. Majority of the side effects here also are transient and they are ocular only. Systemic side effects are less common. Conjunctival hyperemia, corneal verticillata, and conjunctival hemorrhage have been found to be the most common ones, though the verticillata has not been found to affect vision, and the changes have been found to be reversible. If we talk about secondary glaucomas, we do not have a conclusive evidence in terms of the clinical studies that have shown these drugs, that is ROCK inhibitors, to be efficacious in them. If we consider the other uses of ROCK inhibitors, they have found good outcomes in using the drugs in corneal endothelial diseases, and there are other areas where the drug is still being studied. Then the other combination that is available, that may be available soon, is netaserdyl latanoprost combination, which was FDA approved in March 2019 for use in primary open angle glaucoma and ocular hypertension. The advantage here is that there is a supraadditive effect of the two drugs, and it has been found that almost 40%, that is 30.9% patients achieved an IOP reduction of more than 40% from the baseline. And it was also the conjunctival hyperemia was the most common side effect. Then we have latanoprostene bunod with the dual mechanism of action, which also appears very promising in terms of control of intraocular pressure. Now, why should we use these drugs is because these drugs have a distinct mechanism of action, and they are mostly used in a OD or BID dosage that takes care of the that may take care of the compliance of the patient, and they also therefore help in like simplifying the regimen in patients who are using multiple medication. Very good in patients with cardiovascular disease, and would be good in patients where we are finding the patients to be they're finding it difficult to use the prostaglandin analogs. Also in patients with uveitis or where the prostaglandin analogs are not effective. So thank you so much for the time.
Thank you, Dr. Reena, and I would request Manish sir to just share some clinical pearls with the audience. In the meantime, I'll request Dr. Neelam Verma to come and just see her slides.
Thank you, Dr. Reena.
Thank you.
Now, when we look at these newer drugs, there is always some sort of fantasy involved that they are going to change some things. For me, they are more as an adjunct. I'd like Dr. Saurabh to just give me some idea of whether they are treating these drugs as a primary therapy or as an adjunct to whatever we are trying to use. The second part of the question would be the combination of latanoprost and netaserdyl. Since both of them are used once in a day, is it available at your place, and whether you think that is going to substantially change management strategies?
We don't have these drugs available in the UK. They have not been approved. Yeah.
And what about the adjunctive use or as a primary therapy in any situation, do you think? Any of these Rho kinase inhibitors?
So my view is, because I have seen some patients who come from India, they are on 6 drops, and only eye, advancing glaucoma. And I find even these cause red eyes, the nitrosylyl Rho kinase inhibitors. So my concern will be mainly about side effects in the long term, and also surgery effect on the surgery. I don't know enough about these drops to guide you on these.
So I think in a general consensus, I would say that we use it more as an adjunct.
Yes.
Both, is the panel agreeing on that?
Yes, yes. Always second or third line drug, probably third line.